Hello to everyone. I am Dr. Metin Aytekin, working as PR Director for ISSCA Association. Welcome to our webinar program today. As ISSCA, we organize the webinar programs at least twice a month. All our webinars are related to stem cells or any treatments of regenerative medicine. Today, our guest is Professor Dr. Tunç Akkoç. Dr. Akkoç has completed his undergraduate education in the Department of Biology at Marmara University. After then, he got his Master of Science degree in the Institute of Health Sciences. And afterwards, he got his PhD degree in the Department of Child Health and Diseases of the Faculty of Medicine. He is currently a faculty member at Marmara University in the Department of Pediatric Allergy Immunology. Dr. Akkoç is also a founder and board member of the Stem Cell and Cellular Therapies Association. He has made important studies in the field of immunoregulation of allergic diseases, apoptosis, immunoregulatory properties of mesenchymal stem cells, and their application in disease models. He also worked atopic dermatitis and immunoregulation at the SIAF Institute in Davos, Switzerland. Professor Dr. Tunç Akkoç has many awards and publications on the subject regenerative medicine. Today, Dr. Akkoç will share his speech with us titled COVID-19 and Mesenchymal Stem Cell Treatment, Mystery or Not. On behalf of ISSCA, we thank him very much for accepting our invitation. Welcome, Dr. Akkoç. And I leave the microphone to you to inform us about the COVID-19 and mesenchymal stem cell, please.
Thank you.
Dr. Akkoç, can you hear me?
Yeah, I'm hearing you, and can you hearing me? I am speaking, and can you hear me?
We do hear you, Dr. Akkoç. We do hear you.
Okay, now it's working, yeah.
So, okay then, thank you so much for this nice presentation and invitation for me to speak in this nice platform about the mesenchymal stem cells and also the COVID-19 treatment. And first, I would like to share my screen, and then I will start my speech. Okay then, so today I will try to explain all of you about the mesenchymal stem cell treatment. Is it mystery or not in COVID-19 disease? And this is actually my last paper's title. I try to understand what the mesenchymal stem cell do in this viral disease. And let's talk about, let's first see the outline of my speech. I divide into 3 parts, and in the first part, I will talk about the concept of the stem cell. What is a stem cell normally? And I will give about 5 or 6 slides about the stem cell concept and information about that, the basic knowledge. And then I will try to explain the immunology of the COVID-19, because we should understand what are we face and what should be discussed in the treatment of the disease. In order to understand the mesenchymal stem cell application and the treatment approach, we should understand the disease status. And also, in the last part, and maybe the most important part, we'll discuss the mesenchymal stem cell treatment approach to the COVID-19 disease. So first, let's talk about some basic size, the basic mesenchymal stem cell concept. And we know that in a development stage, we see the totipotent cells, which is very potentially high in the fertilized egg and the totipotent stem cell in the embryogenesis. And the first type of stem cell actually, and maybe the most pluripotent stage, is the Blastocyst stage in the embryonal development. In about 5 or 6 days of this development stage, when you take the inside, the inner cell mass to the outside, if you culture that, you get the embryonal stem cell, and which is really big potential to develop and give rise all of the layers of the embryonic development. And then afterwards, we face the mesenchymal stem cell, which are really multipotent stage. And in the clinical and also experimental studies, we normally use these multipotent mesenchymal stem cells. I will discuss more detailed later. And what are the types of stem cells? The hematopoietic stem cells, embryonal stem cells, mesenchymal stem cells, and inducible pluripotent stem cells. But today's topic is the mesenchymal stem cell. So, what is the mesenchymal stem cell and how we get them? From what kind of tissues that we get these mesenchymal stem cells? Actually, there are lots of sources: bone marrow, umbilical cord, and adipose tissue. You can easily derive mesenchymal stem cell in the in vitro environment from these sources, tissues, and the organs. And one of the important things is the description of mesenchymal stem cell, how we describe it. There are some receptors that found on the mesenchymal stem cell. What are these receptors? They are actually, they form a name for that mesenchymal stem cell: CD105, CD73, and CD90. They are the mesenchymal stem cell expression molecules. And of course, they should not express some hematopoietic cells markers on their surface. So afterwards, the other important thing is their differentiation to other tissues, and this is important for the clinical applications. Actually, one of the important thing is the behavior of mesenchymal stem cell. How they behave. They behave differently in the low pro-inflammatory cytokine environment and also in high pro-inflammatory cytokine environment. Normally, our body is in a hemostatic stages, and without any disease, without any microbial or other stimulation, also autoimmune stimulation, without all of them, it is normally found in a low pro-inflammatory cytokine stage. So it's in steady state. And they are in a moderate level, and they activate neutrophils and T cells, and they do not induce any immune cells. But in high pro-inflammatory cytokine levels, what's happening? At that time, mesenchymal stem cells this time activated, and they directly stimulate and modulate the immune cells. For example, suppress the natural killer cells, suppress the T cells, suppress the dendritic cells, and also suppress the macrophage, but M1 macrophages, which is the inflammatory macrophage. And also it induced and it tried to make a balance at that time, the T regulatory cells that try to make a balance between Th1 and Th2 immunity, and it suppressed the autoimmune disease by that way, and allergic disease by that way, and also induce N2 macrophages. It is also important in the anti-inflammatory macrophage and also tolerogenic macrophages. And also there's a big question about what it makes in the tumor, in any effect on the tumor growth. As we know that tumor microenvironment mostly form with, in the niche of the tumor, there are M2 macrophages. So because of that, it will be risky to use mesenchymal stem cell in the tumor because it really stimulates and feeds the niche in the tumor cell environment toward the tumor growth. And when you pick up all them, they are isolated from bone marrow, muscle, adipocytes, Wharton's jelly, dental pulp, dental follicle also, peripheral blood, skin, lung, chronic villi, menstrual blood, and breast milk also. They are all of sources of the mesenchymal stem cells. You can isolate them in your laboratory. They are multipotent and self-renewal, and also they show some markers, as I said before, and they adhere the plastic areas and their spindle shape. And also they should differentiate to osteoblasts, chondroblasts, and adipocytes. So this is the main characteristic of mesenchymal stem cells. If you really want to develop your mesenchymal stem cell from one of these tissues, you should show all of these features in your laboratory. They're also attractive tool for clinical application, as I said, because they're easy to isolate, expand in vitro, and they also restore tissue damage. This is important. As I said, normally it makes an immune regulatory activity, and also it restore the tissue damage. So help the tissue regeneration, promote regeneration and tissue homeostasis. So interfere with the proliferation, activation, and function of immune cells by altering both innate and adaptive immune system. As an immunologist, I can directly say that mesenchymal stem cell modulate innate immune system and adaptive immune system. And in COVID-19, we can see the innate response, inflammatory response, and also inflammation coming from the innate immunity, and also Th1 immunity from the adaptive immune response. So because of this modulatory effect, so mesenchymal stem cell really modulate this activity. And also they can be delivered with matrix, and you can develop a scaffold outside, and you may feed the scaffold with this mesenchymal stem cell, and you can apply the scaffold in some of disease, maybe some bone injuries, and maybe skin, or maybe other parts. You can make a scaffold and use by this transporting equipment. And also the other thing is there are some small molecules secreted from mesenchymal stem cells. They reduce cell injury and induce tissue repair. So as mesenchymal stem cells are the cellular therapy, and they may some risk also in a very small amount, it also can be used their secreted forms, the secreted molecules, exosomes, for example, they can be used. And in one of the study we will discuss later, they use mesenchymal stem cell exosomes for COVID-19 treatment. So there are some therapies also coming from the mesenchymal stem cell injection. They can be seen in clinical trials when you search it there: the cardiac damage, kidney disease, spinal cord, liver injury, GVHD also important, Crohn's disease, rheumatoid arthritis, lupus nephritis also. You can see these treatment approaches in the clinical trials. And the other thing that mesenchymal stem cells secured in the lung, they are immune evasive. So this is important actually, because the most important useful part of the mesenchymal stem cell is the application of these cells from the autolog, and also allogenic transplantation is important. If you take mesenchymal stem cell from other person, and if you want to use it to the other one, so there will not any immune reaction. This is important for using area of the mesenchymal stem cells. And also they are immune modulatory. Also, anti-inflammatory effect, antibacterial, antiviral effect, lung fibrosis inhibition, lung tissue regeneration, anti-apoptotic of injured cells, and alveolar fluid clearance, extracellular vesicle production. So when we see basically these concepts coming from the mesenchymal stem cells, we can easily think that, so we can easily use maybe these cells with those outcomes in COVID-19 disease, because we saw most of them in this disease state. And also, I want to give a little idea about my lab. Our research expertise in stem cells we use in the murine models and in vitro studies in asthma, myasthenia gravis, diabetic retinopathy, neuropathic pain, and we all publish them. Actually, you can find them in PubMed. And Crohn's disease, for example, hepatofibrosis, sepsis. Sepsis is important. I will talk about sepsis because I will talk about these two papers, because as we know that at the end stage of the COVID-19 is the sepsis. The patient died because of the sepsis outcomes, actually. And what are the effects of the mesenchymal stem cell in this sepsis situation? Let's talk about that. I will talk just two papers before going on the immunology of the sepsis, very shortly. We develop a model, the animal model, rat model, checkal ligation and perforation sepsis model, and we applied human dental follicle stem cells, so xenogenic transplantation, you see here that. And we applied these cells, mesenchymal stem cells, in a different period. In the first time that we developed the model, it means that there is no inflammation. We developed before inflammation at the time, and we applied the mesenchymal stem cells after 4 hours that the inflammatory process started. So this is important that mesenchymal stem cells start to work after inflammation, not before inflammation, mostly. And we will see what's happening at that time. The results show that CD4 and CD8 numbers really increased after applying the mesenchymal stem cells, also in first time and after 4 hours application of mesenchymal stem cells, we show the increased CD4 and CD8 levels. This is actually nice, because we will talk about the COVID-19, the decreased lymphocytes levels. So we should increase CD4 and CD8 levels in the COVID-19 also, you see. And increase FOXP3 levels. What is important here, it means that it regulates the immune system. I mean, it suppresses the inflammatory activity. And when you look at those results, after the application of mesenchymal stem cells after 4 hours, it means that inflammatory process already started. So mesenchymal stem cells really work more hard, actually, that it's stimulated and increase the FOXP3 levels and also decrease the TNF alpha levels. This is also a nice result, actually. It decreases the inflammatory process more because at that time it faced more inflammatory media, and also IL-10 levels, you see it a little bit decreased, but there's no any difference. And what about the histological outcome here? When we check out the pathology of the intestine here, we show the regenerative capacity of mesenchymal stem cells got better after 4 hours of application, you see. And also, we know that there is a multi-organ failure occur afterwards in sepsis. And mesenchymal stem cells located there. We use mesenchymal stem cells then intravenously, and they located in the inflammatory area. It's important for homing mesenchymal stem cells to this inflammatory area. And the other study that I want to talk about you is the clinical. I mean, we studied with sepsis patients' bloods in the in vitro and the septic shock patients' blood in the in vitro. We took these patients and we cultured them with the mesenchymal stem cells, with the dental follicle mesenchymal stem cells. So sepsis is a two phase of reactions. The first reaction in the sepsis part, for example, there's a pro-inflammatory cytokine, the immune activation, hyperimmune activation can be seen that. But in septic shock time, there is an immune suppression occurs. So immune response really decrease at that time. So mesenchymal stem cells should behave according to these different stages. For example, when we check out the IL-6 levels, we can easily see that both in sepsis and septic shock, they decrease the IL-6 levels. And TNF alpha level, they decrease the TNF alpha levels. This is good actually for us in vitro in experiment. And when we check interferon gamma, normally interferon gamma level is really increased in the sepsis, in the hyperinflammatory, hyperreactivity phase, but it is decreased in the septic shock normally. And in the septic shock, they increase the interferon gamma level. So it stimulates the immune system, it means that. And what about IL-4? IL-4 is the immune-specific cytokine. And immune-specific cytokine increase normally in the septic shock, in the later phase. And it should decrease this immune specific phase. It should suppress that phase. So we later showed that, I mean, it's better to pick up these results here. The left part is the interferon gamma level, right part is the IL-4 level. So this septic shock patients, we saw increased interferon gamma level. This is important because there's a decreased interferon gamma level at a time. It should increase that. It should stimulate immune system. And other part, it decreases the IL-4 level. So as we see from these results, mesenchymal stem cell behave due to around stimulus. And by taking these signals from outside, they modulate the immune system by that way. Okay, let's come to SARS-CoV-2 this time. Again, in one of our study, we showed, we described the immunology of the SARS-CoV-2, what's happening. We know that SARS-CoV-2 mainly coming from the blood and maybe intermediate host and pass through to human being and then transfer to the human directly by that way, by adopted infection actually. And symptoms, we all know, fever, cough, and fatigue. And in the severe cases, mostly, the virus located in the bronchial, in alveoli. And what's happening over there? Once the virus reached this area, it should go inside, okay? So we really talk about so much about that the receptors, ACE2 receptor, and attach this receptor, and by this way, go inside. And once attached that, sometimes it really give a damage to the alveolar cell by CD8 positive T lymphocyte. This is important. Don't forget that we talk about CD8 positive T cells. The number of CD8 positive T cells really decrease in a disease state, in a severe stage of the disease, and really give a damage, leads to apoptosis of cells, so epithelial damage will occur. And other process, dendritic cell take this antigen, and normal immune response, it stimulates the CD4 T cells, and Th1 cell develop the different kind of cytokines, and as a protective response, they develop an antibodies also. And also Th1 cells form a cytokine storm. And a more developed picture can be seen from the last publication from Jason Makdish and with his colleagues. It's a really nice publication. I advise you to read this paper to understand the immunology of the COVID-19, what's happening. Directly we can see that there's a big damage on the epithelia because of the virus, and natural killer cells and CD8 T cells really give damage with the perforins and granzymes. They act on the epithelial cells. And also dendritic cells take for the cellular immunity and humoral immunity also coming from by CD4 positive T cells. Stimulation and the cytokine storm also will occur. And the B cells are stimulated by Th1 cells. And what's happening? The IgM, IgG, and IgA, the protective virus-specific antibodies are formed afterwards. That. This is the normal activity of the immune response. But by forming these activities, as a result of what is the outcome of that part, the outcome is the antibodies normally. But don't forget that in some patients, we cannot see these antibodies. I mean, they may be positive, PCR positive for SARS-CoV-2, but they may not develop antibodies. And as the virus enters the body, this is normal immune response. About 7-9 days, after 7-9 days, the specific, virus-specific IgM first expressed, and then IgA and IgG expression can be seen. And this IgM expression may continue till maybe the 4 weeks, but the IgM expression will be so high and go in a stable state. But it is really not known how long these IgGs stay in our body. So we should look at a long follow-up to understand that. And also IgA is important because it is a mucosal immune response. IgA also increase at that time. So in a majority of the patients, in a week, for example, self-limiting viral respiratory disease typically occurs. Self-limiting is important, which ends with the development of neutralizing antiviral T cells and antibody immunity. This is important. This is a normal, quick, and recovering result. And IgM, IgE, and IgG type virus-specific antibody levels are important measurement to predict population immunity against this disease and whether cross-reactivity with other coronaviruses is taking place. Also, they may already found in our body because the cross-reactivity of the other coronavirus families. It should be noted that many aspects of severe patients are unique to COVID-19 and are rarely observed in other respiratory viral infections. What are them? Severe lymphopenia and eosinopenia seen in these patients. This is important. CD4 and CD8 levels decrease. Mostly CD8 levels decrease. And the number of these lymphocytes really may be predictive of the disease stage. We will see. Extensive pneumonia and lung tissue damage can be seen. A cytokine storm leading to acute respiratory distress syndrome and also multi-organ failure leads to sepsis. And so as a result of this slide, lymphopenia causes a defect in antiviral and immunoregulatory immunity. It can be result of the activity. Although it's clear that asymptomatic cases exist, this is really known, the real percentage and how long they carry the virus are not known. Also, it should be followed up actually. So IgM, IgG, and IgA antibodies are important to understand the population immunity. And as I said that the percentage of lymphocyte is important and it may be device for prognosis of the disease state. For example, if it is more than 20% blood lymphocyte percentage, it's actually good to recovering stage. But it is less than 20%, about between 5 to 20, it's a severe disease. So it's risky in a second time point in about 17 and 19 days after. And if it is less than 5% percent, and it's still severe and it's critically ill at that time. This is also a very critical situation. So also, there are other results coming from the biochemistry results. It has really increased serum reactive protein and ECR procalcitonin increase. IL-6 really increased so much, ferritin increase, and also you see all of them normally increase afterwards in the disease stage. Also acute phase reactants, for example, CRP levels are also important to understand the disease stage actually. So what is happening at that time? The summary of the immunologic characteristics of COVID-19. T cell response we can see at that time, and then lymphopenia in severe cases, less than 20%. Initial lymphopenia is predictive of severe disease, we see. What about the CD8 level? CD8 level also decrease at that time. It's absorbed in the CD8 positive T cells. In severe cases, it's less than 5%. Th1 and Th2 response is important. Normally, Th1, Th2 response is good to understand to recovery phase. But the cytokine storm is coming from this response, Th1 immunity, an inflammatory response from the innate immune system. This is important. Eosinophils, decrease eosinophil numbers, decrease circulating eosinophil numbers seen in the hospitalized patients. Specific antibody levels, when we check out that, IgG levels increase in the convalescent stage. Cytokine storm is important, coming from innate and adaptive immune system. This is really understand the, in the severe cases. And also acute phase reactants, it is really important, important for understand the severity of this disease. And the ideal immune response to SARS-CoV-2 infection or the vaccination, normally what should happen? In this infection stage, what's happening actually? T and B cell immunity should develop. For what? For neutralizing virus. The putative or the dream vaccine also should develop the immunity for that phase. What is important? The important thing is the low dose SARS-CoV-2 infections and high dose SARS-CoV-2 infections. What's happening that in the low dose SARS-CoV-2 infections, effector T and B cell immune response develop. Okay, the virus-specific neutralizing IgM and IgJ antibodies are developed. Afterwards, rapid viral clearance is good. So low dose response is good for us, but high dose may be the risky for us. Lymphopenia, immune suppression, inefficient T and B cell immunity, cytokine storm, and destructive immune tissue inflammation. We should discuss when we should use and apply the mesenchymal stem cell. In which phase we should use the mesenchymal stem cell is also a discussing question. And the result of high dose SARS-CoV-2 infection is the severe disease, prolonged viral clearance, organ failure, maybe low thick disseminated vascular coagulation. After intravenous transplantation of mesenchymal stem cells, now let's try to link this two concepts. After the intravenous transplantation of mesenchymal stem cells, they accumulate in the lung. And they may, and they mostly do actually that, show its immunomodulatory effect. How? Protect alveolar epithelial cells. Reclaim pulmonary microenvironment. This important microenvironment, which is important, and it reclaim the pulmonary microenvironment, prevent pulmonary fibrosis, and cure lung dysfunction. This is really nice to activity of mesenchymal stem cells. But there are some unsolved problems for treatment with mesenchymal stem cells. Immunogenicity, limited cell source, and ethical issue as the main limitations of this therapeutic approach. But let's look the positive parts, positive way. They are easy, accessible, and can be isolated from various tissues such as the bone marrow, adipose tissue, including umbilical cord, dental pulp, menstrual blood, buccal fat pad, and fetal liver, etc. They are multipotent stem cells. This is important. They are it means that multipotent means that they can transdifferentiate to the alveolar cell. Mesenchymal stem cells can easily expand to clinical volume in suitable period of time. This is also important. For example, if you want to use mesenchymal stem cell, you take it from a laboratory, from GMP lab. And for GMP lab, for this site, they should be isolated quickly and expand easily, and you should get a high number of mesenchymal stem cells in a suitable period of time. And it can be stored and repetitive therapeutic stage. You can store them in a suitable conditions, And clinical trials for mesenchymal stem cells so far haven't shown any adverse reaction to allogenic mesenchymal stem cells. This is also important. They shouldn't give any adverse reaction. What the most important question is that there's a safety of effectiveness of mesenchymal stem cell also have been obvious documented in several clinical trials. They are the good parts. And the overall result, the immunologic effect of mesenchymal stem cell, where are they coming from? We talked about that. The effect of mesenchymal stem cell modulated by the mediators secreted from the mesenchymal stem cells, like prostaglandin E2, TGF-beta, and IDO and IL-8, and these mediators stimulate immune cells. They stimulate regulatory cells. They suppress natural killer cells, CD4 positive T cells, CD8 positive cytotoxic T cells, and gamma delta T cells, and stimulate B lymphocytes to secrete immune modulatory and cytokine like IL-10 and TGF-beta also. And also in other parts, stimulate the recovery phase and multi-inject differentiation to other cells. And also it's summarize the effect on the immune system, induce regulatory B cell, regulatory T cell, regulatory dendritic cells, induce M2 macrophages. This is important. Suppress M1 macrophages. Okay then. So let's come some results. They taken from the, using with the mesenchymal stem cells. This is an example. It's not for the COVID-19 treatment, but also for acute respiratory distress syndrome. It's also seen in the COVID-19 normally. And they used mesenchymal stem cell. What kind of mesenchymal stem cell? Menstrual blood, allogenic menstrual blood derived mesenchymal stem cells. And they give these mesenchymal stem cells in ARDC syndrome to epidemic influenza A infections, age 7 and 9 infected patients. What is the outcome of that? When they check out the X-rays, the radiological development, they showed after 5 years the really recovery phase and improved radiological results picture, and they really easily you can see the opacity is really downregulated by that way, and also bronchiectasis, linear fibrosis are really recovered by that way. So it stimulates the regeneration of the lung also. And the result is that from this study, we can see that 17.6 patients died. It's a control group, but in study group, 55% people died. Recovered, sorry, I missed the result. Just only 17% patient died in mesenchymal stem cell group. Otherwise, the other group is about 55% people die. Almost half patients die at that group. So the recovery is about 5 to 1, is nice for the mesenchymal stem cell transplantation. When we check out clinical trials, actually, we can see that they really use some treatment approaches with the mesenchymal stem cell to COVID-19 patients. The interesting thing that they take different number of patients, 100 patients, maybe 29, maybe 56 patients enrolled, and they use different mesenchymal stem cells coming from different sources. For example, umbilical cord mesenchymal stem cells, adipose-derived mesenchymal stem cells, adipose tissue-derived mesenchymal stem cells, also dental follicle mesenchymal stem cells, Barton's yearly mesenchymal stem cells. They use different kind of sources. But you shouldn't forget that. We should follow up for a long time. It is really difficult to say directly these directly the result of these clinical trial studies, we should follow up maybe 1 year to understand what's happening. But in the acute phase, the acute results showed really the immunomodulatory effect of the disease. Easily control the disease by the application of mesenchymal stem cells. Just patient or case studies can easily show that. The other study is interesting, really. This time they transplanted AC2 negative mesenchymal stem cells. So there's another problem is that if the mesenchymal stem cells really infected by this virus, this is another question. So by that reason, they use AC2 negative mesenchymal stem cells, and they use this mesenchymal stem cells in COVID-19 patients. So they give this patient about 1 million per kilogram cells. And then they give about in 40 minutes and speed of 40 drops per minute. And the result of this study, they take 7 patients. And the result can be seen that 3 patients are recovered after 10 days of treatment. So what kind of improvement can be seen? This is important. What kind of improvement can be seen? You see that IL-10 level, we talk IL-10 level. This is immunomodulatory cytokine. It has already increased with the mesenchymal stem cell treatment. VEGF increased and TNF-alpha decreased. And the overall results is important to understand the mesenchymal stem cell application in the treatment of the COVID-19. It increased, the peripheral lymphocytes were increased. It's good, actually. C-reactive protein, CRP, decreased, as we see that before. CRP levels are really so high in COVID-19 patients, and also lymphocyte number decreased so much in these patients. So it enhanced the lymphocyte number, it decreases CRP level. This is good outcomes. And overactivated cytokine secreting immune cells, T cells, CD4 T cells, CD8 T cells, and natural killer cells disappear. It means that antigen-specific, virus-specific T lymphocytes are decreased, and normal, non-reactive immunomodulatory cells increased. And also, regulatory dendritic cell population increased. This is good because then in the immune system, dendritic cell activation is important for what? To stimulate the immune activity. So these dendritic cells are increased. Immunogenic, inflammatory dendritic cell decrease, it means that. And the level of TNF-alpha level significantly decreased. This is also important to understand the suppression of pro-inflammatory response, and IL-10 responses increase. Actually, when we discuss these results, they are really nice outcomes. And when we talk about the immunological outcomes of the COVID-19, we saw all them are controlled by this mesenchymal stem cell application. And the other point is the exosomes and the microvesicules coming from the mesenchymal stem cells. They're important in the immunomodulatory activity, and maybe we can easily reach the exosomes, and it is an acellular therapy approach. Maybe more safety and maybe, ethically more reachable molecules. And again, they give exosome-derived from bone marrow mesenchymal stem cells. They derived exosome from bone marrow mesenchymal stem cells, and they use them in the severe COVID-19 patients. What's happening at that time? We see that, again, remember the previous slides, increased CRP levels, it downregulates CRP levels, it downregulates ferritin, the dimer, and the neutrophils, and total lymphocyte level increase. You see CD3 levels increase, CD4 levels increase, CD8 levels increase. This is good, actually. We know lymphopenia, and it modulates and it increases CD4 and CD8 T cell levels. In the severe cases, don't forget that. Severe cases, CD8 levels will decrease enormously. Maybe activation. Or maybe inside this immune war. And the original mechanism of action of mesenchymal stromal cells, it acts on the innate immune response and it acts on the adaptive immune response. It downregulates M1 macrophages, induce M2 macrophages, downregulate natural killer cells, downregulate TNF alpha levels, and induce also IL-10 and also induce Th2 cells and T regulatory cells for immunosuppressive and immune regulatory phase, downregulate Th1 and IL-17 levels. We all see increased Th1 and Th17 levels in COVID-19. We all see increased M1 macrophage, natural killer activity, and TNF alpha levels. So it may be useful. Who knows? We know actually if we use mesenchymal stem cells, we can see easily. And we are approaching the end of the speech, but before that, this is also a nice slide. You also can reach the paper. What do mesenchymal stem cells do in SARS-CoV-2 induced lung injury? It's also searching. Don't forget, it's also searching. Non-viral induced acute lung injury, we know what's doing mesenchymal stem cells. Induced loss of, this immunomodulatory effect. But also we are searching what the mesenchymal stem cells do, really do in SARS-CoV-2 induced lung cells. It's available, the preclinical data is available in small and large ARDC in animal models. Clinical data in non-viral related disease is available actually now. The ongoing studies, maybe more than 40 clinical trials studying for COVID-19, their ongoing studies, we will see. And also preclinical studies also ongoing about the transgenic AC, human AC mouse models. And the missing points is the established preclinical model for COVID-19. There is no any COVID-19 model. We just try to study with the animal models with human AC2 transgenic model. And also what's missing, the published clinical trials is not published yet. And the dose understanding, the exhalation curve, they're all missing. So we all get these results timely. And I'm going to finish by that slide. What we are seeing in the COVID-19, the current therapies, the convalescent plasma therapy can be done to patients. Antivirals, anti-inflammatory treatments, hydroxychloroquine can be used, and the vaccine also are waiting. And maybe the mesenchymal stem cell is an important approach for the therapies for the COVID-19. We already talked about the cytokine storms actually, and these cytokines act on a mesenchymal stem cell. This is important. So inflammatory environment is important for working mesenchymal stem cells. For example, please do not forget that in the GVHD, before transplantation, if you give mesenchymal stem cells to the patients before transplantation of hematopoietic stem cells, before development of GVHD, mesenchymal stem cells do not work. I mean, you should use mesenchymal stem cells after formation of GVHD, after the inflammatory process. So because of that, the timeline is important. Using mesenchymal stem cell treatment in also COVID-19 is really important. My idea is to use immediately the cytokine storm started. Okay, at that time, mesenchymal stem cells start to work. they squeeze some mediators, induce some cells, Tregs, Bregs, and into macrophages. And it leads to tissue regeneration and suppress the old immune activities over there. Okay then, I want to thank to everybody to listening to me. This is the end of my speech, and again I want to thank to organizing committee ISSCA for inviting me to talk here.
Thank you very much, Dr. Akkoç. It was very informative talk, and it is really nice to hear that the mesenchymal stem cell could be an alternative treatment for COVID-19. And if participants, if you have questions, please unmute your microphone and ask yourself, or just write your questions on the chat box below, okay? And I would like to ask you actually something. First, what is the real function of EC2 receptor? I would like to hear from you. And then, after treating the patient with AC2 negative mesenchymal stem cell, whether do you think these stem cells are having AC2 receptor once they start to differentiate, or they don't have the receptor at all anymore?
They are good questions, thank you. I want to start from last one. Actually, AC2 receptor normally found in most cells actually. The abundance may be difference, show of difference. And actually, I don't know really what time they're expressed, but they normally express also in a very little amount of AC2 receptors. It's actually an interesting study to understand that, but normally if the other clinical trials do not downregulate AC2 receptor normally, and they give these mesenchymal stem cells directly, I think it will not affect so much this receptor in adverse reaction for adverse effects. This is my idea. Also, it uses another receptor virus. You know, there are two important receptors that mesenchymal stem cell, virus enter the tissue. It's important to touching that tissue to. I didn't talk about the viral entrance. I skipped that slide. It catch there, and inside it broken its envelope and go inside the tissue. Because of that, it's important. This receptor is really important for virus. The two receptors are important to entrance of the virus to the tissue.
Oh, okay. Thank you very much. And the other question, you were speaking about the distinct response to high and low dose virus exposure and infection. And what means low and high dose? Can you explain a little bit more? How do you call low and high?
The viral load. I mean the viral load. If viral load is less, not so much, so patients may recover and develop immediately the antibodies, and they recover without staying in a hospital normally. The lower viral load. But in a higher viral load, this time virus may reach to the lung, mostly down in the downstream area, and then they accumulate there and enter the lung easily. Okay, if they are really captured and in a very low viral load in the upper areas, so the immune system may recover itself. And all of studies show that in a higher viral load, show very severe cases, very severe picture of the disease actually.
Oh, thank you very much. It's very clear now. And do you have any questions? You can just unmute your microphone and ask questions, or write on the chat box below. I can ask another question. Because I read some articles, some patients, they were treated with mesenchymal stem cells, but think about a patient with severe COVID-19 and he had mesenchymal stem cell therapy and recovered. So, is there any way to prove that this patient is actually cured by stem cell therapy, but not his own immune system or not for anything else?
No.
Mm-hmm. Yeah, this is very difficult, isn't it?
It's really difficult to understand because you normally use your therapies. Okay, you do not cut your therapies, stop your therapies, normal therapies. So you actually add another therapeutic approach. But how we understand that? If really we label the cell with GFP, and if we show this GFP cell in the lung, for example, accumulated in the lung, and if we show that the trans-differentiation of the lung epithelial cells, alveolar cells, you can say yes, mesenchymal stem cells can work. It's really difficult to say the real result. And also it's also difficult in all clinical studies, actually. This is also interesting. It's also difficult to say for all mesenchymal stem cell applications that's coming from the mesenchymal stem cells.
Yeah, that's great. I see. Any questions? Let me check.
I have one, Dr. Metin.
Yes, Dr. Akif, welcome.
Unfortunately, I missed almost 75% of the interesting talk. I'm an internal medicine physician. There has been a dilemma because I was in a journey actually, but I'm now settling down. I didn't pull over actually. I'm in my house. Anyhow, there was a dilemma at the very early stages of this COVID-19 pandemic regarding patients who have hypertension and diabetes who are on medication, which is AC receptor blockers, which is a common drug, you know, and this virus is very much related to enter the cell and cause the disease by the AC receptors. Have you noticed any difference to your mesenchymal stem cell therapy, whether the patient on this medication or not, and responded well or partially? I know the numbers are a little, but has there been any striking feature to your experience?
Actually, I didn't use mesenchymal stem cell to the patients yet. And the around results are really coming. It's a good question. The application of stem cell to the different stage of patients are important. And afterwards, maybe the results coming, that we can easily discuss, maybe speculate the results. And also AC2 receptor and the blockers are really important. And also there are some conflicting ideas about using these drugs, as you know. And actually, we should wait about the results. It's very difficult to speculate the result, actually, from my side.
Okay.
Any other question? If there's no more question, there's one question, I think. Dr. Akkoç, can you read it from the chat?
I mean, again, I try to keep myself make some sentences, but for speculative sentences, actually, from here. In clinical trials, the question is which mesenchymal stem cell, which source is good for the COVID-19. To understand that, we should again wait the clinical results. But mostly, I mean, the mostly in other disease states, in autoimmune disease or other disease, umbilical mesenchymal stem cells can be used. And again, in these clinical trials, we face lots of umbilical cord mesenchymal stem cell treatment approaches, dental follicle mesenchymal stem cells approaches, and also adipose tissue mesenchymal stem cells approaches. They are doing that, which are easy to reach and easy to develop stem cells. Maybe I mean, after 1 year in the long follow-up, after long follow-up, we will see the which one is the best actually. And also, please do not forget that the exosomes are also another option for the mesenchymal stem cell treatment, as I talk about one of the paper there.
Any other questions? Okay, if not, on behalf of ISSCA, I thank Dr. Akkoç very much for accepting our invitation, and I would like to close the webinar. And thank you for participating, and please follow our website for the future webinar series. And thank you very much, Dr. Akkoç, for coming and explaining us about the COVID-19 and mesenchymal stem cells.
Thank you so much, and also I want to thank ISSCA on behalf of you, and also the participants and the questions. It's very so nice to talk about it. It's like conference actually, but I really prefer to talk face by face. I hope soon we will make our congress face to face later. And I guess you are going to put this talk in YouTube or somewhere else?
Yes, we do. Yes, we do.
I want to listen myself.
Okay, I will let you know, and I will let all.
And Dr. Metin, is there any announcement regarding our next meeting for ISSCA?
We do have. Let me put on the chat box our banner, which I was preparing actually. And September 9th, we will have another webinar about the stem cell clinical application in urology. Please see our banner on the chat box. And September 19th, we can see, and you can join to our webinar if you are interested on those stem cell clinical applications on urology. Okay, thank you very much, everyone, and have a good night. And thank you very much, Dr. Akkoç, again. And see you September 9th.
Thank you, Professor Akkoç.
Thank you so much.
Bye.